good afternoon to all of you. First, I want to say thank you to the leadership of the IFOPA for allowing me to participate and inviting me to participate in this great conference. It also was a privilege, a lifetime privilege, to meet inspiring individuals like Dr. Kaplan, like Dr. Shaw, and Amanda Kelly. It's a great journey, it's a learning experience, and all is done in a way how to make the anesthetic management and the perioperative journey of any patient, definitely of the patient affected with FOP, a safe one. Because there's one word that we can put on a flag of anesthesiology is how we can make this journey safe. And there is no difference if it's a regular patient, a regular baby, or an FOP baby, or an FOP patient. Same parameter, and that's how we want you to feel. You have your unique situation, and we'll talk about it. One of the things that I'm asked infrequently, so we talk about anesthesia. When was the first anesthesia really happened? Okay, let's talk about it. Here is the first anesthetic, and you can read. And the Lord God caused deep sleep, anesthesia, to fall upon Adam, and he slept, and he took one of his ribs, and he closed up in the flesh, and there is no question. It comes from a great authority. Nobody can argue. So this was the first anesthesia. But no one is coming to the hospital to have anesthesia. You have surgery. So when was the first surgery? Okay, let's talk about it. So we talk about, and the Lord, well, he can be the surgeon, he can be the anesthesiologist, he is the Lord. And deep sleep, as I mentioned, this is anesthesia. And then we're talking about Adam, so we have a patient, took one of his ribs, a procedure, thoracotomy, and we have a wonderful outcome. Really, it's there. So there is no question. Now you know what is surgery, you know what is anesthesia. I'm done, thank you, have a good day. Unfortunately, the story doesn't have a happy ending. And because of this, for generations, those who were subject to a surgical procedure endured pain and suffering. Nobody wants to go to the hospital. Nobody wants to have surgery. Until October 16, 1846, the first time in the history of man, a surgical procedure, small one, tumor in the neck, was done at Mass General Hospital by William Thomas Morton. And Thomas Morton used, you can see in his hand, a small contraption that contained ether. And that's where anesthesia was invented or was done first time. Just for those who love history, 1846, first time ether was used in Philadelphia at Jefferson Hospital, so to show that we are early adapters of innovation and technology. But really, it marks the time that we change the fate of those who go and do surgery. We can make it humane. So one of the major inventions in humankind is actually the invention of anesthesia. Imagine what's life without it. So, talking about our subject, as I mentioned, safety, and we try to make the journey into the operating suite as normal as any other patient without FOP. So the question is, you ask yourself, what do I need to know about anesthesia? How to prepare for surgery in anesthesia? And what an anesthesiologist, when you go and meet him or her, should know about me? So what type of anesthesia are we talking about? Usually we divide them to three types of anesthesia. The simple one, the nerve blocks. The same type our talented friend, Dr. Friedman, is using. You numb a nerve and you can do a procedure and you do not feel much. When you need much larger extent of surgery, you do what we call regional anesthesia. You numb a whole body, you numb a limb, and the surgeon can do what he's supposed to do in order to make us better. And the last one, when it's really extensive and complicated and demanding or needs accuracy. No one wants to do surgery on a moving target, so you do when you go for general anesthesia. So first, we're talking about local anesthetic. These are done by injections. And you heard earlier, injection and FOP don't mix. We do not recommend to have a needle and insert it so it touch a muscle and irritate and wake up the burr. I'm a pediatric anesthesiologist, I'm a pediatrician. Naturally, I say that all pediatric patients have allergies to needles. Same thing, same rule apply to FOP patient. This is one of the allergies. Not to say, highly recommended, go get your flu shot. So I recommend to tell whoever gave or administers a flu shot, use a tuberculin syringe, an insulin syringe, thin 25 gauge needle, tiny, and that gets the job done without irritating anything. Moving on, we talked about the regional anesthesia. We numb half of the body. Can be done for knee surgery, hip surgery. Those among us or you that had to have C-section or labor and delivery, it works. But again, look what's here, a huge needle. Cannot be done, not recommended. On a technical side, I can tell as one who places needles, usually on an FOP patient, everything is ossified. And it's a blind technique most of the time. You cannot find the space. Don't even go there. So we are left with general anesthesia. As you can see here, read, it's a reversible state of unconsciousness produced by anesthetic agent with absence of pain sensation of the entire body. We are asleep. And that's what we use safely for the FOP patients. As you can see here, it's safe, excellent track record, and very good for either if you are inpatient or you go home on the same day. How we do it? We call it by administering inhalation anesthesia. The patient is asleep, he or she, breathing our anesthetic gases, which they go to the lung, and it's always available because we breathe. And as we inhale and exhale, we inhale the anesthetic gases and exchange the gases. It's a reliable, very reliable means of delivering the anesthetic in a very controlled mode. And you wonder, controlled how? So I took, incidentally, 2 anesthesia machines. Here is one, here's another one, and you can see with red circles, canisters that contain the anesthetic gases. We know how to give them. We have the indication. You can dial very accurately and titrate as much needed for the surgical procedure and for the individual patient. So the problem, there is a need to secure the breathing. How you do it? And of course, in order to manage pain, we give very strong pain medications like narcotics. And one of the side effects of narcotics, they can stop the breathing. So really, we have to put everything together and make sure that the airway is open, oxygen going in, carbon dioxide going out, our anesthetic gases go to the right location. So how you secure it? We use a breathing tube. And on a regular patient who can open the mouth, that we come to anesthesia, we put the breathing tube into the windpipe, connect it to the anesthesia machine, done. But the patient with FOP have special needs. And all this can be done by using an expert anesthesiologist. Only the expert anesthesiologist knows how to do it safely. So whenever you go and you need surgery or a complicated dental procedure, extractions, and you are told, oh, even you need an endoscopy, simple procedure, upper endoscopy, colonoscopy, no problem, come, it's a same-day procedure. The anesthesiologist will see you on a day of surgery. And my comment is, it's not a good idea. I call, and actually many of you have met me, I do Skype interviews with patient, families, physicians, some of them together. And the key note is make sure that your anesthesiologist meets with you, see you eye to eye, and do what we call the pre-operative assessment, a pre-flight check. We are very proud that we are the safest profession in medicine, as safe as taking off an airplane. You wouldn't check into an airplane, but the pilot runs after you. Oh, I'm ready, I'm taking off, but you have not been in the cockpit for an hour, checking, going over the checklist. Same consideration. The anesthesiologist needs to meet with you, look at you, and come up with what we call the flight plan, the anesthesia plan. Critical. It cannot be done on the morning of surgery. So, what's an anesthesiologist need to know? Like anything else, we provide our medication, which are very potent medications, given by age and by weight. Our body changes. And you can see here, 10-pound baby, 4 kilogram, has different body composition, emotional state, than the 400-pound patient. Same consideration, but the fine-tuning is there to make the journey safe for both of them. You need to plan earlier. And of course, like any other interaction, educate the physician, the anesthesiologist. He has to give a lot of medication. We are expert in pharmacology. On average, I teach my resident, we go over the 1-hour hernia surgery. How many medication we give? None less than 10, sometimes 15. And each one of them needs to be given by a dose based on weight and height and body composition, and they have the interaction between of them. So if you have any allergies to any medication, bring the list. If you take medication, bring the list. Educate your physician, educate your anesthesiologist. And if you have comorbidities, asthma, cardiac problems, anything else, educate an anesthesiologist. It bears significant weight when he or she has to plan your anesthetic. And most important part, if you have had previous surgery, or your child went to the hospital and had previous surgery, what did we learn? How we can make the experience, if it was good, better, and so on. Recently, I had an interaction with an FOP patient, and I asked her, how was your anesthetic? I thought it was great. And she said, no, because A, B, and C. So we changed our plan. And this time, it was really excellent. So it's very important that you educate and you learn from one encounter to the other. Technology sometimes changes. Maybe we can do something safer or better. So, what else? Tell the anesthesiologist that you are an FOP patient and guarantee 99.99% they have no clue what you're talking about. So tell them, what does it take? What does it mean? If there is a paper or article that you can educate them, and today is the era of communication, they would love to see and learn. And if not, find someone else. Call me. I'll be happy to talk. And I make myself available to most of the FOP community. I have my cell phone number. Not many will do it, but I'm available because sometimes it's urgent, sometimes it's life-saving. And sometimes the consultation is life-saving because if you don't do it, there may be complications. So educate them about FOP. And as I mentioned, He must meet with you prior to the day of surgery. Urgencies happen, I understand, it can happen. But if it's not an urgent, if it's a scheduled procedure, make sure that you meet with him, with either one of them, and talk about the disease and the procedure and try to come up with a plan that you both comfortable with. Again, educate, 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 tell them about it. Just an example. We call this what you can eat or drink before surgery. You don't have to remember it, just an example. So here you have age, here you have fluids or solids, and most of the time for the adult population, we tell everybody you can eat and drink until 10 o'clock or midnight before the day of surgery. However, we have learned from our pediatric patients that you can drink. And I advise my patient or the parents, give the child something to clear liquids, water, Pedialyte, apple juice. Make sure that it's clear. You can read the newspaper through the bottle. The child feels better, the parent feels better, I feel better. So you're allowed to drink. We don't cancel surgery if someone had something to drink up to 4 hours before surgery. And if it's a structured institution, up to 2 hours. So it's a challenging process to give anesthesia. You need the expert. If someone can open the mouth, what happens if someone cannot? So just because an individual with FOP can open the mouth, which is great, we still tell the anesthesiologist, if you have to put a breathing tube, it should go through the nose. And those who went through the process know that we pay a lot of attention. And sometimes the process of doing this, what we call nasal fiber optic intubation, may take longer than the procedure itself. But it's safe, it protects the airway, and then we can proceed. So even if the procedure, let's say it's a colonoscopy, something simple on the other side of the body, things may get complicated. An emergency may happen. Accessing the airway through a nasal fiber optic during emergency is challenging, to say the least. So we take our time and we make it a positive experience to secure the airway. So opening the mouth is an option, but I prefer not to use it, and we recommend not to use it. There were cases that where patient had intubation of the trachea when the mouth was open. We use a device we call a laryngoscope. It challenges the temporomandibular joint. 3 months later, you cannot open your mouth. Nobody wants to go there. And we don't want to carve it. So, you need special accommodation because your body is a little bit different. Needs to be padded, needs to be mobilized. And the procedure may last for hours. So it needs preparation, not only with an anesthesiologist, in the operating room. So we update the nurses and the whole team. And as I mentioned, the needles. Tell them that your body reacts differently for needles insertion. So we talked about you cannot open the mouth, you need a special accommodation, and the most important part is here. Assemble a team. As one who reads medical literature, and now it's available to everybody, you can hear about successful surgery and successful anesthetic all over the world. As much as it's rare, so everybody is so happy, they write a note to the medical community, publish a case report. How much you can learn from one case? One case. What we have done, we build a team. We have done many cases, and we're learning from every single one of them how we can improve the process. And that's what makes the difference. So what we have learned to make anesthesia successful. As you can see here, we place you, the patient, at the center of the medical universe. You are at the center, and everybody else coming to you. It's tough in our economical reality to assemble teams, take the time. In a rush mentality, the time is money, right? Wrong. For the FOP patient, we created the space and the attention they need in order to leave safely the hospital after the procedure. In my institution, I took the lead, so anesthesia is here running the process. And you can tell that the most frequent reasons that we see patients to deal with dental problems. Teeth extraction, filling, and so on. And sound like simple procedure, but it takes the same effort. And some of the patients I mentioned have their own comorbidities, so you bring the expert to the fold. You talk to the cardiologist, you talk to the otolaryngologist. Sometimes you have to go and place a patient for observation in the intensive care unit. So we talk to the intensivist. And I put here nursing. Nurses are the critical component of this huge environment that we call the hospital. Everything hinges on nurses. And we have a special group of nurses that have done and familiar with the FOP patient, so they know what to do ahead of time. So it really looks like a well-oiled conveyor belt when we deal with our FOP patient. So that's what is so unique. You build a team, you do it more than once, and you make the system better. And these are the keys to success. And you can see an example. I just took a picture during one procedure at Thomas Jefferson University Hospital at the operating room. So here you have the ENT surgeon, you have the dentist, Dr. Nussbaum, those who remember Dr. Nussbaum, a Jefferson medical student standing there because we teach the next generation. I admit, I'm guilty. This is my daughter. And here is Dr. Elaine Kilmartin. She's an anesthesiologist and a resident. We always make the resident doing the case with us so they can grow and go wherever they go and teach the other generation. And Dr. Kilmartin has done something that's never been done. She took all the experience that we have accumulated caring for FOP patients over a 10-year period and published a paper. And I do not see this type of paper will be published in my lifetime. How long it takes to take one patient? How about 60 or 70 procedures? You need a few 100 million people to feed this experience. And we are proud that we went through this journey. So this will be out. It was accepted to Anesthesia and Analgesia, one of the prime journals in anesthesia field. It will be available to everybody, and we can post it on the website, I hope, so everybody can go, take the paper, and show it to the anesthesiologist. So, how we continue and prepare? As I mentioned, we prepare the preoperative area, prepare for the airway management, communicate with a specialist, and as we know at home, communication is a key, not to say between our colleagues. Communication is a key. Talk to each other, and you communicate with a specialist. And you set up a system from the admission to the holding area, to the operating room, recovery room, and beyond, so it's FOP compatible. A few pictures to share. This individual lives in Philadelphia. The only part that still moves in her body is the fingertips, so she can navigate herself to the operating room. And you can tell that we set up on the OR table the blankets and so on, that we will accommodate her body positions so she will feel comfortable. This is a patient who came for us from Croatia. And was a question yesterday that I heard when we talked to our families, yes, blood pressure cuff, no blood pressure cuff. My answer is yes. We place a blood pressure cuff for hours on end. I have not seen a complication. But it gave us critical vital signs so we can manage the patient. It's challenging how you slide the cuff when the hand is stuck to the chest wall. It's our problem. We'll manage. You can put it on a foot, on a leg, but just an example, all the padding that goes in order to make the patient life comfortable before they fall asleep. And of course, we advocate, bring your friend to the operating room. So here we bring our friend to the operating room, and of course, the friend is anesthetized first, and then the patient. And you can see that it's done, we move on. And again, this young patient came to the OR, was anesthetized, no needles, nothing. And after he fell asleep, then we inserted the IV, because I told you, children are allergic to needles, so there is no recollection with acupuncture therapy. And we induced the anesthesia, we placed the breathing tubes to the nose, everything was done safely. And it was another successful dental procedure. Surgery brings pain. The medication that we give may induce nausea and vomiting, but we have the expertise to manage it. So we can take away the pain, we can take away the nausea and vomiting, and eventually, well, life is not heaven, but we try to create this wonderful environment to deal with the post-operative consequences. Few words about our cumulative experience that Dr. Kilmartin has put in the paper. We had 30 patients, and you can see the age range, pediatric, 5 years old, up to 64-year-olds, so you have the whole range. Among them, 19 pediatric patients. Overall, many of them came because more than once. In this paper, we describe 42 procedures. 86% of the patients went home the same day. I saved you another slide that we put together many of the case reports that were published in the world literature, in the medical literature. One stayed a week, another person stayed close to a month. Only one dental procedure was quoted, and this patient stayed in hospital 4 days. Our patient, most of them go home. If there is no reason, why not? Few may stay, and if you have asthma that needs to be controlled, if you are too sweet, you have diabetes, and we have to titrate and make it better, we invite you to stay with us in our Jefferson Hotel and manage the diabetes and few other medical issues. But most of the patient can safely be anesthetized and go home. So here is the Jefferson hub. In Thomas Jefferson University Hospital, we have a center and patients coming to us almost from every continent. Our team goes out. We've been to South America, we've been to Luleå, for those who remember, in meeting with our Scandinavian patients. We went to Israel. And as you can see here, this is after surgery, a major oral maxillofacial surgery in a patient in Israel, Dr. Nussbaum, the family. This is Dr. Idit Matot. Now she's the chairman of a major institution, and I can entrust her to take care of FOP patients if they are from Europe or anyone from anywhere from Asia, and she knows what FOP means. She can provide safe anesthesia and organize a team around the patient. Personally, we heard about personal dreams here, and my personal dream is to make sure that when we look on this world map, on every continent, there is a team that can safely provide the needs for surgery and anesthesia for FOP patients so they don't need to travel. And it's always much nicer to stay close to home, especially during vulnerable time of your life. So in a summary, what we can recommend that a multidisciplinary team will be assembled to take care for each time patient with FOP comes to the operating room. Patients should be treated with corticosteroid. That was a common theme across the day. General anesthesia is safe and can be safely administered to FOP patients For dental procedures, this was a study, but I can extrapolate to other procedures. We recommend and we actually advise teams all over the world to learn and to have only experts that can do nasal fiber optic intubation in order to safely manage the airway. And most patients can be discharged on the same day of surgery. Another thing that I would highly recommend, how you prepare yourself. Sometimes it's like the Olympiad of the medical life, training. And if you have to train one part of your body to make sure it stands the stress of surgery and anesthesia, or any other life challenges medically, lungs. I cannot state stronger. Train and exercise your lung. How you do it. If you can do any physical activity, if you can, that make you sweat and breathe heavily, that's great. You take a deep breath, you sweat. If you can still go to the water and do water aerobics with someone guiding you, trust me, you can sweat in the water. And if not, use what we call spirometry. Yesterday I went to Amazon. How much costs this plastic device that causes spirometry? $8, 14, I think one was 18. Not much. Investment worth it. You do this respiratory exercise, you take a deep breath, there is a small balloon that goes up and down like a ball, and you can see numbers. I recommend write down the numbers, date it, put aside. Come back a month later. During this month, every day, do your breathing exercise and check what are the numbers. It may be lower, it should be higher, because you train yourself and you should be doing better. So another message, invest in yourself, train the lungs, do incentive spirometry. It's cheap, it's simple, and it's worth it. Thank you very much. I'd like to entertain any questions and wish you a good day. Thank you.
Good afternoon. I really don't have a question. My name is Scott McGuire, my wife Colette, and our son Cameron. But I do want to relay two experiences that we had. One had to do with Cameron needed oral surgery in 2005, and we came to Jefferson Hospital. I just wanted to thank you for the blessing that was and the help that you gave Cameron, because the provider in our area, he really didn't want the liability, and he wasn't willing to do that. So I appreciate that very much. And the other thing, Cameron broke his neck 5 years ago, and we encountered that very thing with the anesthesiologist, where they're wanting to get done with the procedure and move on. And we said, well, it has to be done a different way. And there was a resistance there. And we also got Dr. Kaplan on the phone. There was a consultation. It worked out fine. But you do really need to be an advocate to make that stand. And that worked out in the end. But I just wanted to thank you for all the help you've given us. Appreciate it.
Thank you. Any other questions?
Dr. Grunwald,
yes.
My name is Peter Litt. My son Daniel saw you a couple of years ago in Philadelphia prior to some dental work. And thank you again very much for your help. He is now 19 and attending college in California. When he was a pediatric patient, we had a pediatrician who was very open-minded, who read things, who investigated ways of doing things, and our anesthesiologist was also our neighbor. So we had a very good anesthesia plan set up. When you're transitioning to adult care, or he's in college, which is a somewhat temporary affair, how can we best assure his safety in having as good an anesthesia plan as we had for him when he was younger?
Good question. Two comments. Number one, have a simple medical letter, 1 page, that state diagnosis, allergies, age, weight, and so on. Number two, what I recommend, there are med alerts that you wear on your wrist. Diabetes, asthma, so on. he should have a med alert on the wrist that states FOP, or I don't use abbreviation, Fibrodysplasia Ossificans Progressiva, difficult airway, because he may be traveling on a highway, simple accident, appendicitis. It may not be even life-threatening, but needs urgent care. The team in the emergency room, the anesthesiologist will see him, will see the med alert. And the other thing, as soon as you come to the hospital, today you have electronic medical record. Make sure when they ask about allergies, we have in our hospital, and it's not so simple, it took us years to establish it, that now airway issues are as allergies, because you have to resolve airways issue fast. I'm telling my residents that if a patient under anesthesia has a problem, sometimes only God can save him, and even then, God has 3 minutes. So make sure that the issue of the med alert and the difficult airway is in the allergy section of the medical record, because anybody, including the nurses, comes to treat the patient, they pop up the screen, they see allergies, and here comes the issue of the airway. And even can open the mouth, tells them no intubation, you have to have nasal fiber optic. So all these small things will put together some kind of a safety net, so when care is needed urgently, it can be rendered safely. Any other questions? Yes?
Yeah, you mentioned about pressure cuffs. I noticed that you did it for oral surgery. Is it because they took prednisone first that they never had a reaction to the pressure cuff?
We looked, actually, it's another good question, about how many of our patients, and we have 40 procedures, had prednisone. 1/3 of them did not, for various reasons, awareness, old days, and so on. None of them, as far as we know, has developed any side effects from any of the instrument that we placed on our patient, and some of the procedure lasted for hours on patients that had advanced disease. I'm not sure that they had a flare-up, but no question, it was vulnerable time. So I'm not aware. So when we talked about the questionnaire and what to put and how many questions really you can ask, I know that space is limited, but I just put my request on behalf of those who may need surgery, asking about surgical procedure during the lifetime, anything acute, because we have to learn. And we don't have good information, and this is not something trivial. It's surgery and anesthesia. I'd love to hear from our patient what their experience. And I can tell you, as much as I'm proud with what we deliver to our patient, just a week ago, I learned from one of our more elderly patients coming to surgery that the technique was not perfect, and we modified it. And this is a time it's not fun. You come to the hospital, surgery, apprehension, and so on. Anything that we can learn to make it safer and better, if you don't ask a question, if you don't read the numbers, the answers, and you look over large patient population, how else you can make the system better. So that's my request. If you can, at least one question, we can talk about it related to the surgical or perioperative experience of our patients. Any other questions?
Can I just go further on the question?
Yes,
I just want to ask another question. Because I really want to clarify, get understanding of this, because I always refuse for my son to have a pressure cuff, because I do not want him to lose any movement he has. Do you find that certain ages may react differently to certain pressures on muscles, or you have no idea? I don't, again, I can talk from experience, and we have experience from age, at least you saw here, 5 years old to advanced age. And it's also important how it's related contemporaneously to flare-ups. Although we never canceled the procedure because someone was close or after or during a flare-up needed the procedure. Usually it's done because it needs to be done. I'm not aware of any consequences for our monitoring. And we have to have monitoring, because otherwise how we can tell when you provide our care with very potent medications where the margin between safety
and non-safety is very slim, especially in the pediatric population. We have to monitor vital signs.
If the child goes to the doctor's office and does a daily or a regular checkup, is it okay to have the pressure cup?
I'm happy that you asked the question. It came up in our clinic. How you build this database, and I'm calling the medical database. That now it's not just your database and the medical database, all different. But you want to know how the child is doing, or any patient with FOP, and the respiratory part is so important. So I think you have to build, when you go to the well clinic or the periodic checkup, weight, height, and you also blood pressure, heart rate, and pulse oximetry. I'm not sure how frequently we do it. It's a vital science. You measure temperature. It's a vital science. Now, pulse oximetry is not just another vital sign for the FOP community. Because the respiratory compromise that does not get better with time, how can I document better that I have a change? If I measure it, you put it on a finger, doesn't cause any harm, brings a lot of information. I would advise, if you are in more advanced stages, do it standing up, doing lying supine. Because I watch the patient for hours on end with all the fancy monitoring, and I can tell you position at certain patient may be affected on a pulse oximetry reading, I mean oxygenation, how much oxygen goes to different parts of the body. So blood pressure cuff, heart rate, and pulse oximetry, part of the routine checkup, and you look at it over time. I've seen many patients coming from all over the world, blood work, hemoglobin, hematocrit, other chemical parameters. I'm talking basic vital signs, and this is important to have the vital signs over time. Any other questions?
Yeah, I'm Nancy Sando, and I just want to encourage and share just a little bit. When my jaws fused more than 20 years ago, I participated in a difficult airway clinic at Michigan, the University of Michigan, and they nasally intubated me as kind of a, quote, experiment long before the fiber optics was just being kind of invented for difficult airways, and that was the last time I've ever had to have it done. Fortunately, I've never had any surgery since then, which is a big blessing, obviously, for obvious reasons. But now those, since it was done successfully with, a little bit of difficulty, of course, but now my local doctors can have those records done, and I've also contacted my local anesthesiologist, just kind of as a here I am, and just to make them aware that I live in the community that I do, so they can all be aware of, any, like you say, appendectomies or any emergency surgery, so they are all aware of the difficulties that might present if I need surgeries. And, fortunately, I live in a fairly small community as well, but they are all very much aware of the situation. And I think that's the key of being very proactive in having a unique situation. And I just wanted to share that with everybody that, if you go out in your communities, there are difficult airway clinics available. You just have to kind of search them out. So thank you.
Nancy, thank you. Very good point. I wish it was so simple, because you never know where you end up, who will be on this shift at 4 a.m. or 4 p.m., and it's challenging. But the awareness is there, and I can tell you in the anesthesia community at large, and the American Society of Anesthesiology has addressed it. So all these extra instruments, and we have different instruments that we use at our disposal in order to safely manage the airway. Nasal fiber optic is now one of the things that we train all our residents. And even a nurse anesthetist, I opened a nurse anesthesia school at Jefferson, we know that one of the first simulators that we built was a fiber optic simulation for nasal fiber optic training. So it's a growing knowledge in anesthesia community, and communication and awareness is the key. Thank you. Any other questions? And if not, thank you very much.